Copyright, University of South Australia. This recording may contain third-party copyright material. Apart from any use permitted under the Copyright Act 1968, no part of this recording may be reproduced or rebroadcast by any means or process without the prior written permission of the University of South Australia and the copyright owners.
Hello and welcome to another practical video. What we're going to be doing today is having a look at and talking about the arm, elbow and forearm region, then also having a look at the hand bones again, as we would have in the pracs on the Monday. Let's do a bit of revision first. So some of the things that we can see in this picture from right when we started back on the upper limb. We've got our sternoclavicular joint here between the sternum and clavicle, our acromioclavicular joint laterally out here. And we know that the sternoclavicular joint was the more stable one of the two. This joint here then was the glenohumeral joint, or our shoulder joint. We spoke about that. At the elbow here, we talked about the fact that it was the primary articulation between the ulna and the humerus, and that the radius did not specifically contribute to the elbow joint itself, but does exist within the joint capsule. But where the radius comes in is we have the two joints at either end. We have the proximal and distal radio-ulnar joints. So having a look at the bony model here, we can see this is the proximal end of the ulna and the radius, and the distal end, obviously, because that's where the wrist is. Some of the features that we can see here on the ulna, which we haven't been able to see previously, is there is a notch here in the bone, and we call this one the trochlear notch. Now this notch here is actually where the humerus sits in. So that prominence there where you can see the ulna articulating at the elbow is called the trochlear of the humerus, and so naturally that fits into this notch, therefore we call trochlear notch. The rounded end that you can see here articulating with the head of the radius is called the capitulum. Alright, so if you think about that's the head capitulum, so here's the head of the radius articulating with the capitulum. Some of the other bony prominences we can see around the elbow region here is we can see those medial and lateral epicondyles, and we remember that we discussed that coming from the medial epicondyle was the flexors and the lateral epicondyle was the extensors. Some other muscles that came from those medial and lateral epicondyles were muscles like pronator and supinator. So let's just revise how pronation and supination work. So we said that the ulna was the bone which is going to primarily stay still, and it's therefore going to be the radius which is pivoting upon the ulna. So here with the palm up, remember that we can hold sup in this position, so that reminds us of supination. And then as we turn the hand over, what you can actually see is the radius has pivoted. It's come across at the radio-ulnar joints, and now we are in the pronated position. Having a look at some of the other bones that we have in the wrist region, we said that the wrist was made up primarily at the radiocarpal joint. And you can see here that this gap, whilst it's a little bit exaggerated in this model, sort of does exist like this at the wrist joint between the ulna and the carpus. So we did say that we had motions like flexion, extension. Then whilst this model's not going to do it well, but we have radial deviation and ulnar deviation. So radial deviation as the hand is moving off toward the radius, and ulnar deviation as the hand is moving off toward the ulna. These bones in here, if you remember the mnemonic, so we had the so long, the pinky, here comes the thumb. These are the carpal bones, so 1, 2, 3, 4 in the proximal row, and 1, 2, 3, 4 in the distal row. The scaphoid is first, the lunate second, the triquetrum here, which is primarily on the posterior aspect. You can see the triquetrum in the pisiform, with the pisiform sitting more on the anterior side and the triquetrum on the posterior aspect. This here with this hook, this is the hamate. Then the capitate, the head of the wrist in the middle, the trapezoid, which is completely trapped by all sides, and then the trapezium we said was with the thumb, so trapezium and thumb. We then had the 5 metacarpal bones, so 1, 2, 3, 4, 5. Interestingly, you can actually see here that each of these distal row carpal bones articulate with 1 or 2 of these metacarpals. So the trapezium with the first, trapezoid with the second, capitate with the third, and the hamate with the fourth and the fifth. If you did have a look at the foot again, you would find that the cuneiforms and the cuboid articulate in a very similar manner. Then we had this joint here, all right, between the metacarpal and the phalange, so our metacarpophalangeal joints. 1, 2, 3, 4, 5, and in our skin they're the knuckles, if you remember us talking about that. In the thumb, we will only find 2 phalanges, a proximal phalange and a distal phalange, therefore a interphalangeal joint found there. But in each of the other fingers, just like each of the other toes, we would find a proximal interphalangeal and a distal interphalangeal joint to separate proximal, intermediate, and distal phalanges. So these you can see, obviously, when you flex your fingers, you'll find those different components there that can be moved. So what we're going to do is we're going to have a bit of a go at talking about some of the other primary structures that we have discussed in the past. So as an example, we're going to talk about the blood supply. So let's do some memory from this one. So in here we put the heart, all right, so the heart coming across and occupying this space here, and we'll talk about the heart in this position inside the thorax in more detail later. Then we said coming out of the top, we had the arch of the aorta. So the ascending aorta coming upward like this, then the arch of the aorta coming across and going over like this. From there, we had one primary artery on the right-hand side, which would then go up and feed the head and neck after it divides and one goes into the arm. And then on the left, we had 2 individual arterial branches from the arch of the aorta, one going directly to the head and the other going out to the arm like this. So let's do our best to try and remember these names. This one is the common carotid, which we'll discuss in more detail later, common carotid artery. Alright, then we had this one coming out on this side. This was the subclavian. And if you were to be specific, it would be the left subclavian. Then we have the right common carotid and the right subclavian artery here. Now, if you remember from the lecture, we discussed that this is a primary trunk on the right-hand side. We called this the brachiocephalic trunk, which we will discuss in more detail. And then it would divide nearby this joint here, the sternoclavicular, into the right common carotid and right subclavian arteries. So the right subclavian artery is going to be therefore significantly shorter when compared to the left, as it goes from the sternoclavicular joint and passes up and over the first rib. Now beyond the first rib, so at that point, at the outer margin of the first rib, this is where we have the change. So from the sternoclavicular joint to the outer margin of the first rib, we have our subclavian artery, so our right subclavian. As it then passes behind the clavicle and into our armpit, we know that this one is to be called the axillary artery. And the axillary artery, once again, passes down anterior to the scapula and would pass by and into the arm. So it would have been there at the position where we found our teres major muscle. So if we put a dotted line across like this, that demarcates the end of the axillary artery. And the beginning of the brachial. From there we said that the artery would continue, go through the anterior aspect of the elbow and through the cubital fossa. Once it passes through the cubital fossa, next to the median nerve and the bicep tendon and the brachial vein, it would then divide into radial and ulnar arteries. Now we haven't gone into the hand yet, that's what we'll be discussing this week, and we'll be talking about how that blood supply comes into the hand specifically. But if we just introduce it now, so these arteries come along specifically with the radius and specifically with the ulnar, which would make sense. The radial artery then passes to the dorsal aspect of the thumb. So it actually passes behind passing behind the thumb and going through that anatomical snuff box we spoke about. Passing through and then emerging into the hand and coming in between the first space here of the first and second metacarpals. The ulnar artery passes just lateral of the pisiform, comes through like this, and these guys actually join inside the hand, and that word is to anastomose. Don't expect you to remember that, but that's the word that it's used to describe this. Now, where it comes off the radial artery, it actually goes into a deeper aspect of the hand, and when it comes off the ulnar artery, it becomes more superficial inside the palm. So we would call this one coming off the radial the deep palmar arch, and coming off the ulnar artery the superficial palmar arch. So the deep palmar arch is going to supply things like the thumb and the radial side of the index finger. And then the superficial palmar arch here, what it does is it gives these common digital branches, which then go off and supply each side of the other respective fingers. So we call these the proper digital arteries. So this is how the hand gets its blood supply, and we'll do a bit of a trick in the lab a little bit later just to show you how this works. Now if we go on to describe the brachial plexus and the set of nerves that's associated with these things, like we talked about in the lecture class, the word that we were going to be using to remember the brachial plexus was mamu. So wanting you to remember the 5 terminal branches of the brachial plexus once again. So let's put them in perspective here. We'll use a few different colors to try and help show that. But the ones that I'm really worried about that you know are these ones. So we know that the first M is musculocutaneous, is axillary, the next radial, median, and ulnar. Now we talked in length in the lecture about how these things get to their respective positions, and so if we just use big block colours for those 5 different branches, what we can do is we can show their general appearance and how they get to where they're going. So the brachial plexus we know is made up of the nerve roots of C5, 6, 7, 8 and T1. So, and then we remember that the cervical ones come from above and the thoracic ones from below, and then C8 comes from between C7 and T1. So the musculocutaneous nerve would travel like this. So from C5 and C6 and C7, all right, I won't draw the C7 in this time, but it will come down, go underneath the clavicle, travel out this way, and then down the lateral aspect of the forearm, and end with having a sensory area here on the lateral forearm. So musculo, because it's going to be innervating the muscles of elbow flexion, and cutaneous for the area of skin on the lateral forearm. If we put the radial nerve in now, let's do that one in red. So our radial nerve is going to be coming from primarily from C7, but it has all of them. So it comes along like this, passes under the clavicle once again, and then we remember that because it starts with an R, it actually means it's going to go behind, so it's going to go through the rear. So it's going to pass through the radial groove on the posterior aspect of the humerus. It then winds its way around the lateral epicondyle through the cubital fossa, and then once again passes onto the posterior aspect of the radius to innervate those forearm and elbow extensors. Continuing on the back, then you'll find it coming through the snuff box, but then also continuing into the posterior aspect of the hand. So this one's going to run through the back to the whole way. If we do the median nerve, well actually first let's do the ulnar nerve. So if we do the ulnar nerve first, the ulnar nerve comes primarily from C8 and T1. It passes most medially, and that doesn't really make it easy because we've got the median nerve and the ulnar nerve, which is medial, but they are 2 different words. Passes most medially. We remember now that it passes down and behind here. And what was that area called? Cubital tunnel. From there, it'll pass through the flexor carpi ulnaris, nearby with the ulnar artery down to the pisiform, and then supply 1.5 fingers inside the palm, as well as a set of muscles which are intrinsic to the hand. The median nerve comes actually not from all the way up here, but from in this region here, where there's a major branch of that lateral part and this medial part come off and contribute to the median nerve, which then travels through the cubital fossa, along where you would find the brachial artery. It then passes down the center of the forearm, median in the middle, to then travel through the cubital, the carpal tunnel, and then to supply the rest of the hand on the palmar aspect. So we'll talk about these in more detail, but there is a picture in your practical workbook where you can have a go at trying to put these in. One more that we need to remember is the axillary. So the axillary nerve, it actually is only a small branch which exists just up here near where we have our glenohumeral joint. It comes off of the radial nerve as a branch, so off this posterior trunk is what we call, and then it passes up and out the back and behind the humerus to innervate the deltoid and the teres minor from behind. So it actually passes from the anterior aspect and goes in and through and out the back. So they're the nerves of those ones. Now if we write a few things about these guys down here, all right, let's detail some of the functions of the musculocutaneous as an example. So just colour in, musculocutaneous was in orange up the top there, so musculocutaneous in orange. So it's going to be innervating a few muscles and then an area of skin as well. So muscles like the coracobrachialis, muscles like the biceps brachii, muscles like brachialis, and then it's going to be innervating the skin. So I'm going to write S for sensory and M for motor. So lateral forearm. The next one we can do over here is ulnar. So the ulnar nerve in green we did. So the ulnar nerve here is going to have motor innervation to flexor, carpi, ulnaris, which we know is a wrist flexor and ulnar deviator of the wrist. It's going to innervate half of the flexor digitorum profundus muscle, which we'll label in a minute in our books. It will also then innervate some intrinsic hand muscles, which we're yet to speak about, but they'll be in the lecture this week. It's going to innervate muscles we call the hypothenar muscles. Now these control your pinky finger. It's then also going to innervate your lumbricals, your third and fourth lumbricals, which we'll talk again in the lecture this week. And it's going to also innervate your interossei. And these are the ones that are going to be abducting and adducting your fingers. One more is also the adductor of the thumb, so adductor pollicis. The median nerve then, let's label that one. So the median nerve we had in blue, so you can see it there coming through the carpal tunnel, through the center of the wrist. We know that it comes through the carpal tunnel with the long flexor tendons. This is going to be innervating more of the forearm muscles rather than more of the hand muscles of the ulnar nerve. So some examples of those: flexor carpi radialis. Now this is one thing not to get confused, is just because it says radialis doesn't mean that it's going to be innervated by the radial nerve. Remember that it's a flexor, so therefore it will be innervated by the median nerve. Flexor carpi radialis, flexor digitorum superficialis, pronator teres and quadratus. Flexor pollicis longus. And then the other half of flexor digitorum profundus. So grouping the muscles by nerve is not a bad way to do it. It does seem that there's like a lot of information, but it will come eventually. It is also going to do some intrinsic hand muscles. So if the ulnar nerve does the pinky finger muscles here, the median nerve will do the thumb. So you can see that the blue, its innervation is coming off here towards the thumb. So instead of your hypothenar muscles, it's going to be innervating your thenar muscles. And then it will also be innervating those leftover two lumbricals, the first and the second lumbrical muscles. Now let's do our radial nerve. So that's that one that was in red. So radial nerve, radial red. We know that's going to be innervating the posterior aspect of things. So if we start from all the way up here, and we know that muscles are going to be on the posterior aspect, the radial nerve, and remembering Saturday night palsy, is going to be innervating your triceps brachii. It's going to be innervating supinator. And then it innervates all extensors of the wrist, all extensors of the fingers, and extensor and abductor of the thumb also. So I'm just going to write it in shorthand here, because we're going to go label them on another bit of paper in a minute. But we have extensor carpi radialis longus and extensor carpi radialis brevis. Then we would have extensor carpi ulnaris, extensor digitorum. Then we're going to have extensor pollicis longus and extensor pollicis brevis. And finally, abductor pollicis longus. Alright, join me shortly for the next video on drawing these in. Good.